Look at the number of tests done, 6.5 million. And just look at this graph here, the world map. You see a red color, a bloodbath. You see how it is across Far East Asia, how it is across Europe, how it is across Great America or Northern America. And now we come to our continent, our own lovely continent. You can see the red dots getting bigger and bigger, the red clouds getting bigger and bigger. So here we are. How do we play an important role as a citizen of the country, as a medical specialist, to erase the red dots, to erase the red bloodbath, or keep it quiet, rather than having this big red cloud coming over us? Very important. Please listen carefully. This will change the way we live. Okay, that is about COVID. Now we move on. COVID has infected a patient. What do they get? How do they present to the hospital? This is from a paper published in March this year. The two main characteristics, the presentation is with high fever. You would have seen, checking at the airports at different areas, that you would have encountered people with something like a gun pointing, checking everybody's fever. That is a typical characteristic of it. And then when it comes to blood results, what we call lymphopenia, a differential count on the white blood cell. Everybody does a full blood count. So everybody has it. The important factor is lymphopenia, which is unlike other diseases. I will tell you why these two are important in a radiology world, clinical and laboratory, why these two are important in a radiology world. Just keep this in mind. Okay, what is the standard of diagnosis today? The standard of diagnosis is a swab in the pharynx. It is not in the mouth, it is not in the nose. It has to go right to the back of the throat. It can go through a nasal route or it can go through an oral route. Have you tried that at any time? If you try and poke and try and go to the back, obviously the first thing you get is retching and vomiting. It's as common as that. If people who have had an endoscopy done would know its feeling. So why I'm saying that is also important. Test is a test, not straightforward and simple, but this is the present standard of diagnosing COVID. So once we do a swab, we do in the laboratory what's called a RT-PCR. You don't need to know this. It is a polymerase chain reaction. But look at the sensitivity of this. Again, this has been published recently in March. It ranges between 38 to 73. I mean, on average, you're talking 60 odd %. So you're talking 1 in 4 people are going to be missed even after a swab. That is why they say you have to make sure you repeat the swab on a clinical patient. That's the current standard. So remember, keep this in mind, and I would say where imaging is going to help, and you are all going to play an important role. I mean, everybody. Okay, we move on to the next slide. Everybody can see this is where imaging comes to our play in COVID. And I'm going to talk on two things, chest X-ray and CT. I hope I'm clear so far. Yes?
Yes, please.
Okay, let's start with chest X-ray, which is the bread and butter of our work. I hope you all agree. As the disease has been only irrelevant to the world, it's called a novel virus. For the last 2 to 3 months, we have very limited literature, and most of the literature has described it on CT. And as you can expect, most of the literature has come from the Chinese continent because the disease originated there. You know, as Mr. Trump says, it's a Chinese virus. I don't know whether we are allowed to say that. If you go back to a little history, it mimics the other coronavirus family which has visited the world. The SARS and the MERS. MERS is a Middle Eastern respiratory virus, yeah? Okay, what does a chest X-ray produce? You will be hearing these names now repeatedly, these descriptions, try and get that into the gray matter of the brain. This is very important. By the end, I'm going to try and see, because I have a wonderful quiz. I'm going to let you answer. We're going to have a polling to see how much have you taken in. Very important. So when you look at an X-ray, very simple. You know, it is bilateral, involves both lung, systemic disease. It is on the periphery of the lung, you know, periphery. I will show you examples. And it is multifocal, number of, you know, dots and lines and opacities. And it is predominantly in the lower lobes. So, you know, you've got 4 or 5 points here, you know, multifocal in the peripheries, in the lower lobes, in bilateral, it's going to show us lines and dots and, you know, just as opacities. This is very typical. Kindly do not talk. So I come from the British standard. As per the British Society of Thoracic Imaging, this is how we report an X-ray. We either say it's a classical, which means it's COVID, or we say it's a probable, which means it's likely a COVID. And then there is an intermediate, well, we say cat on the wall, 50-50, you know, it looks like, but I'm not sure, you know. And then there's an alternative diagnosis, which means it's no COVID. So simple, remember those 4 lines: classic, probable, cat on the wall, intermediate, alternative diagnosis, another diagnosis. Okay, now watch for the films. Okay, have a close look here. I'm showing you some classic radiographs that I have been encountering in the last month. Couple of radiographs are very hot enough. Some are from yesterday and some are from today. Even this morning, I reported half a dozen COVID patients. It's as prevalent. So watch carefully, listen carefully. This group of 3 X-rays gives you everything. You know, this I've been concentrating on lines predominantly and a little bit of dots and shades. Predominantly it's line. Okay. Okay. Remember my words. It is, this is the earliest most feature, you know, it is peripheral. How do you know it's peripheral? Maybe if you have to have a simple algorithm, draw a line in between the center, you will have more and more coming at the peripheries. Here you have, just as an example of what we call ground glass, just a little, you know, opacity, like a small cement, you know, similar opacity coming up here, peripheral, and we have something here as well. So multifocal, predominantly in the lower lobes, involving both the lungs. Classical findings. It is a COVID, it is a COVID. Alert the team, get fast onto it, because patients might not live. The second thing is you have to prevent cross-infection. That's very important. It kinds of moves to the next few days. You see, these are a little more on the peripheries. You see a lot of lines and dots happening here actually, and a little bit of ground glass attenuation. So multifocal, peripheral, both the lungs. Here it is now moving from the lower also to involve the upper lobes, because the disease is progressing, moving.
It's too unfortunate we are not hearing here in Uganda. I don't know.
I hope everybody are hearing. Okay, everyone, can you hear me?
Yes.
Kindly
Yes, we
mute.
can.
So we can hear you.
Yes, we can hear you clearly.
Yes, we can hear you clearly.
Okay.
Yeah, I can hear you clearly.
Okay, fair enough. Kindly check your local net connection and unmute the others who are on the system. Kindly mute it. I don't like this one. Come on, team, behave like adults.
I am in Uganda. I am
I'd like
here.
to unmute here. Yeah, please unmute. Watch. Unmute. Okay, we're going to restart on the X-rays. Sorry for that. I apologize. Okay. Again, as I said, we look at X-rays. We read X-rays on 4 categories. You know, classic, you know, probable, intermediate, alternate or unlikely. Okay, look at the X-rays. Look at the X-rays. You know, ground glass opacities, peripheral, multifocal, lower lobes, bilateral. These are the buzzwords. These are the words which gives us the diagnosis. It has progressed on a few more days. We have multifocal, we have ground glass, we have lines. It's gone from lower lobes. It's also involving the upper lobes. Now we have moved on again. Now you see it predominantly multifocal, ground glass, lines and dots involving nearly all the lungs. Typical of COVID. Be attentive, have a watch, make sure I'm able to reach all of you. Okay, so we move on to the next one, all from lines and dots and ground glass. We have moved on to a bit more of classical consolidation. Here we have ground glass opacification, again multifocal, lower lobes, peripheral, ground glass opacities involving both the lungs. You will be hearing what I'm saying again and again. This has now progressed. You know, you're having consolidation like a bat wing appearance, but again multifocal, mid and lower zones, both the lungs. It has now progressed. We are having multifocal peripheral disease involving the lower, the upper lobes, both the lungs. Now this has progressed more. Predominantly, you're having literally a whiteout lung. You know, you're having most of the lung affected. You know, and this all progresses fast, as you would see on my further slides. This is X-rays. X-rays, again, I shall repeat, peripheral, multifocal, bilateral, lower lobes, both the lungs. Classical finding. We will go through the other findings. Intermediate. Why I call this intermediate? You have, what do you have? Ground glass opacities, peripheral, predominantly in the lower lobes, only on one lung. Nothing much on the left lung. You can call this maybe probable, maybe intermediate. We need, as I said earlier, we need the clinical and the laboratory correlation. This is where we go from 60-70% to nearly 80-90%. Very important. If you look at this, we have a consolidation in the lower lobe of the right lung, left lung, nothing much. Similarly, a peripheral consolidation in the mid zone on the left lung, nothing much on the X-ray. Unilateral appearances. Until we have a coherent clinical history and the laboratory findings, we will be a little bit kind of intermediate in this diagnosis. Now we are coming to alternate diagnosis, which means it is not COVID, which means here, have a look at it. Peripheral opacification could be ground glass. And is this a little bit of opacification on the lower zone right lung peripheral? Could be. But what kind of alerted me was we're having a little bit of upper lobe diversions here, you know, the prominent blood vessels. Look at the size of the heart. It's pretty big. The only thing you don't have is pleural effusions. And I'm thinking, well, you know, I need a little clinical history. And he didn't even come with a fever. He's breathless and dyspneic. And this is a classic cardiac failure, pulmonary edema, not a COVID. You look here, this is pleural effusion. Nothing much on the left lung. Effusion doesn't happen in COVID. You think about it, think about another diagnosis. You look at this radiograph here. This is predominantly calcification of the pleura, mediastinal, hemidiaphragmatic calcification throughout, and this is a typical holly leaf calcification of the pleura. Nothing to do with COVID. We can be sure on these diagnoses. We help the clinical team, you know, to a much larger extent, and the patient also. So with this, I would move on from X-rays to CT. Okay, very important to also know, because from an imaging point of view, we do a lot of CTs. Commonest one, similar to X-rays, here we call ground glass opacification. I will show you examples. Multifocal, again peripheral, again lower zones, again bilateral. If it moves from there, it has a bit of consolidation, and then it starts to form lines, you know, septal thickening in CT squares to a crazy paving pattern. There are some less frequent ones. Of those, think about a reverse halo sign, which I will show you examples. Think about an air bronchogram, you get in a consolidation. You think about a vascular thickening. The vessels get thickened because of the reaction that it has due to the lung injury. You know, all these things are less frequent, but makes you think. The rare ones are pleural effusions and lymph node. I will show you examples of it. Okay. We had a paper published in AJR in February 20. Again, similar to X-rays, bilateral involvement, typical ground glass opacification. Think about it. bilateral, peripheral, multifocal ground glass opacification in both lungs. These are the golden words in CT. We will look at some examples now. As per the British Society of Thoracic Imaging, this is how we report a CT. Classic, probable, intermediate, and non-COVID. Classic, same words, peripheral, multifocal, bilateral, ground glass / consolidation, a bit of reticular lines affecting both lungs. Probable, fairly similar features, but not typical. It's maybe involving a single lung. It might be involving a, kind of like a few other features. And then we have, I'm just waiting for the sound to minimize. And then we have intermediate, which is kind of 50-50. I will go with X-ray, the examples of CTs, and then non-COVID appearances and not a COVID patients. So we move on to CTs, classical signs, what we talked about here. Ground glass opacification. It was bilateral. I've not shown you the cuts on that once, but this is classical ground glass. It's got a very smooth density going through. What is a ground glass? It doesn't affect the architecture of the lung. You see all the structures of the lung very clearly. Bronchi, the vessels going through, everything. It does not disturb the architecture. Whereas when you see it on interstitial lung disease, it disturbs the architecture. That's a classical take-home point. Ground glass opacification. Hope I'm clear. We move on. More ground glass opacification. Peripheral, multifocal, involving both the lungs. The disease has moved on. It's now involving the upper lobes and the lower lobes. This is yet to move into consolidation. Why? Because you see no architectural disturbance. It's not as dense as a consolidation. We see the bronchi, the vessels much more clearly. Multifocal involvement of both the lungs, peripheral, no architectural disturbance. In typical classical signs of ground glass. So bilateral, multifocal, peripheral, lower lobe, both lungs. COVID. Think about it. You will never make a mistake. We further move on to classical signs. More from ground glass, now we are having consolidation coming in. Again, multifocal, peripheral, lower lobes, bilateral, both the lungs. Bang, it's COVID. Now the disease has progressed. Here we are having, in addition to consolidation, we are having septal thickening. You see these lines? Septal thickenings are happening. And it kind of gives you what we call in radiological terms a crazy paving pattern happening as such. Typical of COVID. It's slightly moving along the stages of COVID, which I will talk to you later. Okay, less frequent. This is what I call signs to be looked at. Consolidations in both the lobes, peripheral consolidations, lobar consolidation. We are having air bronchogram signs. Okay, this I can call it intermediate. Is it lobar pneumonia? Is it COVID? Here I might need to take the help of my clinical findings and the laboratory. So clinical discussion comes into place. Look at this peripheral ground glass opacification. This is a Ruiz halo sign. Ruiz halo is nothing but, hypodensity followed by a hyperdensity periphery. Think when you see this. When you come lower down, we have what's called the thickening of the vessels. It is now becoming more and more clearer. Initially, it was a finding which we didn't recognize, but we are now seeing more and more thickening of these vessels in COVID patients. So these are subtle findings, but when you see, think about COVID, we make a difference. So as per the British Thoracic Society of Imaging, how do I report? I say it's a classic COVID. Probable gets me closer to classic. Intermediate, I then go to clinical and laboratory findings, alternative diagnosis. I really help my clinical team in the first two and the third one. It's a huge difference we make as a radiological team. Intermediate, we sit down and talk to them, to the clinical and the laboratory team. Okay, couple of things for people who are looking at CT images. To be a little careful. You get ground glass opacification. I'm going to give you some false positivities here. When you do a CT with contrast, because as you know, a lot of HRCT or predominantly all HRCT should be done without contrast. That's the standard. But if you do with contrast, for then the post-contrast image on the right side, left is pre-contrast, post-contrast, same segment. Look at the carina. The contrast will increase the density of the lung. That is what it is supposed to do. So it gives you a false positivity saying COVID. So just think for a second before you take it up on this. So that is my lesson number one from my experience. Second, when you look at ground glass opacification at the peripheries and nothing much in the lung, just have a think. Use multiplanar reconstruction, which is now available in most machines. These are streak artifacts from the bone. Think about it. You make a difference calling somebody COVID and a non-COVID. The third thing, this is a standard 0.6 millimeter, which most of the centers or hospitals now have. You kind of get, what is this? A little bit of ground glass, there's this little bit of dots, etc. What can I do? I just go for my MIP, 8 or 10 millimeter, beautiful. Lots of dots here, lots and lots of dots. So this is a nodular pattern, well, untypical or atypical for COVID. So think about another diagnosis, makes a difference. So just stop, think for 5 seconds and then proceed. So we now come towards a bit of evidence on CT. Again in Lancet, this April, a paper was published again from China. Initial stages, predominantly you see, it is only ground glass opacification. Ground glass opacification is your primary finding in your initial stage of the disease. As we move through the disease, ground glass gets lower. We tend to get more consolidation and then move to lines, which is called the reticular kind of pattern. So the transition happens at the middle stage, somewhere between 7 to 10 days, and we tend to see other diseases happening. So keep in mind. This is a paper was published in Radiology in February 20. CT progression, the dates are all below, but have a look. Early stages, multifocal peripheral ground glass opacification in the lower lobes of the lungs, bilateral. We move on. The next day, it is predominantly similar appearance. As we move on further, we have consolidation. Here we go, peripheral consolidation, both lobes, lower lobes, both lungs. Here we have a atoll sign, the reverse halo sign. And as we move forward, the consolidation tends to reduce and we tend to have lines forming in, reticular lines forming in. These are classical temporal changes published again in Radiology in this year. You can see, pretty much day 8, we having multifocal consolidation. We moved beyond the ground glass changes, multifocal, both lungs. We move, getting reduced resolution happening by 10-25, patient is better. Changes, temporal changes throughout the CT. So keep in mind, ground glass, consolidation, lines, and then it disappears. Okay, CT and COVID. I'll just now talk the practical points. There was a big hype of whether we can do screening, i.e. every patient can be screened. This came from a ship you might have heard, Diamond Princess, which was parked in Yokohama Bay in Japan. 3,700 patients, i.e. or members in the ship. We did a study. This came from Japan. 112 patients who were positive on the swab, out of which 82 were asymptomatic. So we picked up all the 82 odd patients and scanned them. And in these asymptomatic patients, we were able to identify nearly half of them on CT on the same findings that I've been talking to you about. So moving on further, another paper published in Radiology looked at CT and swab, I mean the PCR test. And again, it compared CT. It was brilliant, 97% sensitive. Nearly we were able to diagnose everybody. But look at the specificity of calling it COVID. We are only 1 in 4, positive to call it really COVID. But CT was so good. It was picking up the early diseases. So this all made a big hype in the media. Everybody from America all the way to across to the world, we said CT is going to be the best diagnosis in coronaviruses and none of us are going to go out of job. Brilliant. So it still carries on. So we looked at the largest study so far published, the largest study in the New England Journal of Medicine, where we looked at 1,000 odd patients. And here we wanted to look at to see whether imaging, this we have taken both X-ray and CT, whether we were able to make a difference in the world of COVID. So what were we looking at? We were looking at one, severity of the disease, and the second was the endpoint, whether we were able to say this patient is going to die, this patient is going to have an ICU admission, or this patient is going to get into a ventilator. Big decisions, big decisions. What did imaging do? We were able to address these findings, which is remarkable, both by chest X-ray and CT in a similar rate. i.e. chest X-ray was calling it as much as CT, which is brilliant. The numbers were very less because I told you initially in China, we did more CTs. We did, the study looked at 1,100, nearly 900 to 1,000 odd patients at CT, whereas only around 300 odd patients at X-ray. But look at the severity, 76. Look at the severity here, nearly, abnormalities on chest CT. Nearly it was getting around 95. Obviously a little better on the severity of the disease, but it was not too bad. But look at the endpoint, i.e. what was the endpoint? Is this patient going to die? Is this patient going to go to a ventilator? Is this patient want an admission? Look at this. The p-values were 56, and look at what on chest CT was, kind of doing. It was 86. We were, chest X-ray, because of the numbers were less, but we were not too far away on the role of it. So we felt, this group felt, chest X-ray and CT has got a big role in COVID. So this is one of the take-home points that I want you to take away. Actually, I said these numbers will change because as we are progressing down the months, we are going to publish many papers, and these will change. As I said, this is an early data. We have had only 2 months of data so far, and predominantly this has been arising from the Chinese continent. Now we will have a lot of papers coming from Europe and America because of the disease. So what do I think is the role of imaging? It plays an important role. It is there. We have to use the imaging in those 4 strategies. And when we come to beyond the classic and probable, when we come to intermediate, kindly get the help of our clinician and the pathologist on the laboratory findings and the clinical findings. And our COVID specificity will be very high. Take it from me, we have been putting this in practice, and as I say, we will release papers very soon on this. So now coming to the last point, sorry, I've been running over a little bit because of a lot of stop and go things. This I think is very important. What does this mean to you and to the hospital that you work at? I will run through this a little faster. We have to start forming guidelines. Guidelines will arise from national guidelines, from what we call the royal colleges, or from the colleges from each country. This is one of it, which said any patient who's undergoing a CT abdomen and pelvis for a pre-surgical indication should have a CT chest. Why? Because if they are a COVID positive patient, their mortality rate at the operation table is higher. So it makes a huge difference. So we have put this in practice. In any CT abdomen with a clinical indication which looks like a pre-surgical patient, like appendicitis, perforation, obstruction, we do a CT chest. Then we have moved on to also prepare local guidelines. I'm giving you some thought process here so that you can take it to your department. We have a local guideline. We have a workflow system. We know how to handle a possible COVID patient in this way, chest X-rays and CT. So this is a line graph. So something that you can also work out. Once you do this, it acts as a standard and everybody in this department follows. It makes it very important. I'll tell you why as we move down. Because of infection control. A COVID patient, a slippery virus can infect us and we can be spreaders. So we have to look after ourselves, and for the benefit of us, our department and the patients, we have to get this right. So I'm sharing you my thought process in my department, what we have gone through in the next few slides also, but keep thinking, any help, I'm always here to help you. So keep thinking, we all have an important role to play as an individual and as a medical personnel. some of the tips which I have followed, I have put it down here, which will help you. Be part of the conversation. Talk to your clinicians, talk to your surgeons, engage with them, tell them, do you see COVID? What can we do? Okay. Think about, can we do COVID or non-COVID CTs, you know, because cleaning, infection control all plays a role. Can we do the last 2-3 patients as the possible COVID patients in a whole list? Something, keep thinking along those lines. Rehearse the patient flow. So everybody in the department knows a COVID patient comes, goes to a separate bay, doesn't stand out in the corridor, you know, things like that. Rehearse. Keep asking specific questions, i.e. vet your clinical forms. If somebody comes with, I'll show you an example of what it happens in my departments. How do I vet my clinical forms? Watch out for the next slide. Have daily radiology rounds. What do I mean radiology? 10-15 minutes of coffee time in the morning. Hey, what did you have? Anybody were you suspicious? So that we learn and we also share the learn. And have the hot reporting, which I will also say. Hot reporting, you know, all you need to do is only look 2 things. What do I do? You discuss COVID films or possible COVID films between all the members of the team, i.e. even the technician, everybody, you know, every little helps. Encourage teaching to everybody, you know, technical radiographers, everybody encourage taking, even the colleagues. So every little helps. Even if somebody is suspicious, we can go far away. So what do I do? We have a hot reporting. All chest x-rays are looked at the same time, the patient before they leave. A hot review of the CT of the lungs and its bases. When you do a CT abdomen, if you're not doing a whole CT chest, look at the bases, very important. This, as a technician, you should be able to do. Ground glass, look at pictures, you will be correct. And when a request come through, I do 2 things. Vet each request. I just put in these questions in the request, which the clinician has to answer. Does the patient have a cough or fever? Is the chest x-ray abnormal? If anything is positive, I think, how do I image this patient? Should I get him last on the list so that it has time for me to get the scanner, and he or she, if it is positive, he doesn't infect us or any other patient. And so we are also able to take precautions, masks, gloves, etc. Keep the staff safe. Very, very important. We have to look after ourselves. So in summary, we have a major role to play in this COVID. Do not think COVID is over yet. We are in the midst of COVID. We have a major role to play here actually as such. So, and I've gone through these things to you. I have 1 or 2 more slides to go. This, I'm putting it up again actually as such. Again, I shall repeat, an important role we have to play if we have to prevent the bloodbath of cloud moving up from north to our continent. Take this message home, how we can play. I've also given you some tips about you personally and your hospital, and I'll be more than happy to help because I'm also your countryman from Africa. So take our advice also, but take this image in your mind.